Hello, everybody. Welcome to the first inaugural CHIP update session as part of the TCTMD CHIP newsletter. My name is Sanjog. Kalra. I'm an interventional cardiologist at Einstein Medical Center in Philadelphia, and it gives me great pleasure to introduce Dr. Farouc Jaffer at Massachusetts General Hospital, Harvard Medical School, who will be our inaugural interviewee for the CHIP update sessions. These interviews are short little bites that are designed to give you the inside perspective from experts in the CHIP field, their best pieces of advice, and a little bit of information about their experiences in the CHIP space as you develop your own programs and as we all try to develop this space. Welcome, Dr. Jaffer.
Thank you so much for having me, Sanjog. It's a pleasure to be here, and congratulations on initiating this really exciting session.
Thank you. Thank you very much. Thanks so much for joining us. This week's interview, or this month's interview, I should say, is entitled The Heart Team in Complex CAD. And we hope to talk to you a little bit about your experience with heart teams and how you've built them. But maybe to start, I'll ask you to introduce your niche within the CHIP space. What is it that you do within the CHIP space, and how does your research contribute to growing the space?
Sure. Well, thank you. And again, it's a pleasure to be here. And I'm really delighted that one of the first topics is the importance of the heart team, because it is central to great decision making that is necessary for best outcomes. Our focus is to really, besides the heart team, is the use of advanced imaging to guide complex interventions, in particular chronic total occlusion CTO angioplasty. And we've been spending a lot of time trying to understand if fusion technology with CT angiography can be reconstructed and put online, fused on top of the X-ray, to allow us to resolve ambiguity and anticipate difficult crossings from both dissection and calcification. And we hope to be able to use this technology to de-stress procedures, especially for those in their upward trajectory of learning where there is some difficulty and stress with dissection and dealing with ambiguity.
And how do you feel that the group at your lab and the members of your division are adapting the results of your research? Are they bringing them on as part of their discussions and their case planning?
For sure. It is really neat to see what happened as a research project is now a commercially approved product. So on certain platforms, we can actually just routinely use fusion, very much like they've done for TAVR in the past for large segments. It's more complicated with coronary segmentation because these are smaller and there's more artifacts. So we do have a little bit of expertise in extraction of center lines. But now it really becomes a routine aspect of saying in these more complicated CTOs where I can't resolve the proximal cap, or there's a very long dissection, or there might be additionally a branch or two that was underappreciated by angiography because there weren't sufficient time for collateral filling. Sometimes we extract things that you may not want to lose, a second diagonal or something at the distal cap, which is underappreciated. So these are things that CT really allows us to get going with, especially when you're going to choose stiff wires, to know that you're in the architecture. We often have a great chance to do that with wiring by knuckling, but sometimes getting started to make your knuckle requires a stiff wire. And that is one time where we actually are, our guard is up a little bit about whether or not we're going to perforate. So having the additional guidance is very helpful in that regard.
And so anecdotally, do you feel like it's made a difference to your practice, your outcomes, how people are discussing and doing cases at your institution?
We are studying this to really understand what is the efficacy and safety with guidance of CT versus non-guidance. We haven't done this in a randomized way, so it's still in that kind of data gathering way. But in proximal cap ambiguity, our preliminary data really suggests that even though these CT cases tend to be more complicated ones, typically higher JCTO scores, just because we end up getting them often for the post-CABG cases where there's diffuse complex disease, that our success rates are about the same, and that our antegrade penetration rate, so getting going antegrade, seems to be more successful, right? Where if you know where the cap is by CT and what the course of the vessels are, you're willing to push forward antegrade. And while we, of course, can do cases retrograde, sometimes the amount of retrograde time is difficult for the patient. Sometimes we can't get our retrograde knuckle all the way to the proximal cap to define it. So being able to start antegrade in certain situations can be helpful.
really the sine qua non of what CHIP is, right? Bringing all of our tools and knowledge to bear to get the best outcomes for our patients.
For sure. And yeah.
So speaking of accessing multiple opinions and multiple tools, I wanted to talk to you a little bit about your experience with the heart team at MGH. Many of us have read your very important paper in the Journal of the American Heart Association from this past April, where you described your experience with the heart team at your institution. Tell us a little bit about it and some of the challenges and solutions that you have found while you've built a heart team at MGH and then as you've analyzed your data.
Thanks for that question, and really credit to Michael Young and Double Colte for writing the paper. They did a great job, and I'm glad it's getting some exposure. The motivation for this is, I think, something that we've all dealt with in our clinical careers, is that in complex cases where there's equipoise, there had often been a individual physician making a clinical judgment for a process of bypass or stenting or medical therapy based on their experience, often based on their personal skill set and their experience in certain clinical situations. And as I was kind of, evolving in the 2010s, really watching this, it began to, dawn on us that we could have very different opinions based on who the individual that we were talking to, both from a bypass standpoint and from a stenting standpoint. And so this concept of anecdotal decision-making became, kind of more manifest to me and seemed like an opportunity to really try to improve the way that we make decisions for individual patients. In parallel with all of this activity, there were many things happening. One was the Syntax trial, and then the Syntax 2 4-year score analysis. When the Syntax and Syntax 2 trial giving us a structure for understanding the complexity of disease, and then when Syntax 2 gave us the clinical variables to help us really predict 4-year risk with coronary anatomical complexity, we really advanced our ability to prognosticate and understand what might be ideal decision making. And then, as you well know, in parallel on the technical side, coronary intervention was certainly advancing with hemodynamic support, total occlusion work, a number of different tools, and then the improvements with drug-eluting stents as well as DAPT allowed us to do increasingly complex patients, often driven by surgical turndown, and then recognizing that we could apply these techniques that we were having to use in those turndowns to patients in equipoise as well. So about 6 years ago or so, I approached our chief of cardiology, Bill Deck, and asked him about whether or not we could try to formulate a heart team similar to the valve work that had been kind of well recognized for aortic stenosis. This was driven by not only my independent thought, but of course ESC and AHA guidelines recognized the heart team importance from the Syntax trial that Dr. Soroy's led, and this was a class 1 guideline. So we had class 1 guidelines, we had this recognition that we could do better for team decision making from the valve world. So implementing that for complex coronary disease was a natural extension in our hospital, but really, again, quite underutilized across the United States and worldwide. And I think that has to do for a number of reasons. When a new technology came out for TAVR, there was both this interest from interventional cardiology and surgery working together in this new domain. Whereas with coronary disease, surgeons and interventionalists had been comfortable treating this independently for decades. So it really took a reset to say, well, you know what, maybe we can talk about these things together and come up with a more team-based approach and understanding where we could have kind of complementary value. And so, and so that was the foundation for kind of really motivating the start of this formal approach.
And so what were some of the most difficult things you had to deal with when you set this up? I mean, for example, interventional cardiologists, cardiac surgeons, often in the same room, everybody has a strong opinion and is willing to strongly advocate for their patients. How do you approach the discussion? Is there a formal process that you use? Who gathers the data? How do you look back at the decisions you've made?
Great. So that was, of course, the most important part is that, can we approach this in a collegial way where we clearly respect our colleagues' expertise and opinions? And even if there is dissent, realizing that the dissent is driven by, clinical interest and different perspectives, and not, a pejorative or, any kind of punitive way to say that person X's opinion is not valid. We really kind of set that process. There was already mutual respect amongst the sections, but they hadn't really worked together in the same way so integratedly for coronary disease. But what we did is we actually basically started bringing patients into the room who had had complex coronary disease and had angiograms. And typically the standard process for surgical disease, if you will, would have been cardiac surgeon will evaluate the patient on the floor, consult is placed. If there was a higher risk situation that precluded a routine outcome for bypass, many of these patients might be discussed or maybe deemed inoperable. But sometimes people would say, I know one of my other colleagues in surgery might be willing to do this case. And then it became clear that, like, by coming into a room together, that they would also understand the interventionist perspective in this case. And so what the way that this ultimately worked is that we brought the two sections together for complex patients. We had a standing meeting set up every Tuesday at 7 a.m. to be able to discuss elective or cases that were ready for Tuesday. But subsequent to this, we now, especially in the virtual meeting era, can do this on an ad hoc basis within 12 to 24 hours. The center of this, so what I wanted to do that was, I think, maybe hopefully a little different, was that rather than just going around the room and showing films and saying, what do you think? We really wanted to actually get the data for guidance. Like, do we actually have tools that can be more than my opinion? And clearly we started to have that with the syntax score, syntax to STS, AHA, and ESC guidelines. Those are all part of that heart team forum. And we're blessed to have fellows that can help us with a lot of this. We have, also in part, and I'll talk about this further, as a consequence of the initial year or two, we recognized that we actually had to set up an interventional cardiology consultative service for exactly these types of patients, so that the interventionalists would actually go meet these patients at the bedside, just like the surgeons, establish a relationship. Because the other thing that I've reflected upon in the last 20 years is that we are too willing to do complex interventions just meeting these patients for the first time on the pre-side. I think that we do not have that relationship with family and patients that the surgeons will have going into their procedures, because they've done formal evaluations on the floor in a calm environment. Sometimes it's hard to talk to a patient for just 5 to 10 minutes and understand their goals of care, what they're willing to kind of go through with, how much support they'd be willing to have, and what's their medical complexity. People have histories of cancer and bleeding and renal dysfunction, and we really have to know that. So a 5 to 10 minute pre-site assessment may not really be sufficient. So we actually started interventional consult service because of this.
That's so very insightful. I think as we push forward in this area of chip intervention, where our cases are getting increasingly complex, the back end pressure to move cases through quickly doesn't seem to have died down. And so putting a consultative service, as you've done in the way, offers a perfect opportunity to create that formal relationship between operator and patient that doesn't have to be rushed, but that can be furnished with all of the information that we as physicians always advocate to give our patients to allow them to make their best decisions. That's a beautiful example of teamwork.
Thanks. I think it also, some fortuitous things happened. Sky advocated for interventional cardiology at that time to become an independent subspecialty. So these consults are reimbursable, just like any subspecialty, EP, heart failure, and so forth. So while they will take more work, it's not a simple, just we're going to fix lesion one. When you're doing the integrated one, I think that both from a physician perspective, having that relationship, even if it's the day before, inpatient, we'll often reach out to patients' families, we'll do Zoom calls, we'll do, telephone calls, and we'll have everybody agree. Because the last thing that we want is a misunderstanding of risk and what the complexity of the procedure was. Yeah. When a patient is told they might have a stent, they often are, kind of believing that these are usually routine procedures. People go home the next day, and often we're blessed to be able to do that, but not always. Mm-hmm. And so if complexity happens or complications happen, having that relationship with their patients where you've clearly laid out your perspective on things, you've listened to them about, again, their wishes and how much they would want to push forward. It really kind of improves the relationship during the procedure with the family, and I think improves outcomes overall.
So that the partnership that you have with your surgical colleagues, and it sounds like with the administration, from a practical perspective, are you limited in the throughput of your complex cases because you're trying to meet around cases on a multi times per week basis, or do you have to sometimes do cases then discuss them afterwards? How do you manage the practicalities of running a heart team in a very busy environment like MGH?
Those are great questions. So maybe I'll just take a sample scenario that we can go kind of from the beginning to end about how this might really transpire. I think that when a diagnostic angiogram is performed and we have complex coronary disease, there are sometimes it's very clear that a particular direction will be approvable on the spot. So either we know this patient has low EF and diabetes and they are a good surgical candidate that's well known, they're going to go to surgery. On the flip side, we know that this person may be extremely high risk for surgery for many reasons going in, we're going to move to PCI. That gray zone where we don't know, we have now been willing to not just jump into ad hoc PCI. The interventionalists, of course, are the gatekeeper right at that moment. We can, of course, guide our non-invasive cardiologists and our patients towards that decision of PCI. And in many cases, it may be the right decision. But there are also times where I think we know that surgery would be a reasonable decision. And again, while the data is still evolving and being revisited with modern technology, we do know that with higher and higher complexity of coronary disease, we may have more durability with surgery. So rather than making an ad hoc decision, we'll pull them off the table, and then we really try to accelerate a consultative approach between both services. So if we know someone is going to be higher risk for surgery, STS scores, more than 3 to 4%, we will simultaneously ask the fluorocardiologist to consider and request interventional cardiology consultation. That can either be the diagnostic catheterizer, or we really actually have a daily service where someone is available to do that consult if the diagnostic catheterizer is busy.
Right.
Then ideally the next morning or the next day, and often these patients who are more complicated do have more workup. They require imaging for vasculature, for support. They may require viability scans. So there's often a day or two of evaluation. During that time, we're working to coordinate the surgical opinion, the interventionalist opinion, and then come together as both sections and the referring cardiologist and clinical subspecialties that might help us make the best decision. Neurology, if there's a history of stroke. GI, if there's history of GI bleeding or cirrhosis. These sorts of things that are important for decisions that may not be available by risk scores alone.
That key detailed approach.
Right. And so once we have the two consult services, seen the patient, then a Zoom meeting or et cetera will be set up, and the sections are invited. And now and again, the virtual world, we have really good turnout. But even before that, we really had strong commitment from the cardiac surgical service and the interventional service to come to these meetings. In those meetings, the heart team form has been filled out by one of the fellows or myself or one of the surgeons. And the most important things that we really are trying to emphasize in there are the STS score, the syntax 2, and then any unusual comorbidities, radiation to the chest, cirrhosis, et cetera. Once that happens, for everyone in the room, all the interventional attendings and cardiac surgical attendings, we'll ask the consult attendings to speak about their perspective on revasc for this individual patient. We'll ask the referring attending, the non-invasive floor-based attending, to also give us their perspective on whether or not there's any particular insights they had for what this patient would want. And then we go down the room and we ask each of the attendings what they would think about surgery, stenting, or medical therapy. What's their recommendation? And we try to bridge consensus that way. And we would say probably 80–90% of the time we will gain consensus. Sometimes there's still some debates, and that's okay. That's the way that life is. I think when people come together, what I've noticed is that there's been a growing camaraderie and the ability to collaborate more on cases, realizing that, you know, we have each other's backs a little bit more than historically, and that people are not trying to take cases just because I can do everything with PCI or I can do everything with surgery. It's what's the best outcomes for the patient that we're hoping to get. Can we work together to get that done?
Do you feel like this approach has resulted in more hybrid revascularization procedures at your institution, where the surgeons might put on a lima and then an interventionalist might do a left main into circumflex or an RCA distally?
Yeah, it's a great question. You know, I thought initially when we did this that was going to occur much more. I think where I am seeing it now is that the surgeons are much more willing to, if they are insufficiently bypassed in the OR for technical reasons, they're much more willing to say, hey, you know, Farouc, would you think about, you know, additional revasc when this person recovers in a month? And that was something that didn't used to happen, which was really great. There are certain situations, I think, for example, one of the things that we've been increasingly collaborating with our surgeons about is if there is focal circumflex and RCA disease, and you have an LAD in a 3-vessel case, and you really believe that probably the best thing for this patient is lima to LAD, but you also wonder about the durability of vein grafts for the other lesions. We have had debates about, you know, maybe we would take care of the non-LAD territory by PCI and then stage this person for lima to LAD in the future, where, you know, it's one thing if they're 95% LAD, then you got to make a comprehensive decision now. But in IFR positive 70% LAD lesions, you may have time to kind of do a hybrid place revasc. And I think those are interesting decisions. It's really the opposite of the hybrid trial, which was all PCI or, you know, lima hybrid plus PCI. This is really or lima plus hybrid plus, you know, off pump minimal invasive CABG. This is really about considering lima and PCI for the non-LAD versus standard CABG. I think is a very interesting question. I think a really important question for our teams in the future.
That's fantastic. And so just to quickly finish up, can you, for those of us who are starting out heart team programs at our institutions, for those who read the newsletter each month and are contemplating getting into the chip space and want the support of their colleagues, what are your top 3 tips for setting up a heart team and being successful?
Great. Yeah. So number 1 is to really build that bridge to cardiac surgery, realizing that you're working together to take care of these patients with complex coronary disease to give them the best outcomes. That because of this bridge that's been built with valve disease, there's the same bridge that can be built to attain optimal revascularization and to help each other in terms of stressful decision making. So I think once that bridge is built, then getting people in the room is very easy. And sometimes it's a cyclical thing. Once you get people in the room, people see each other face to face and they build up that relationship. The second part is to really try to have some structure to the heart team meeting based on data, ideally, as we discussed, STS, syntax, syntax 2, to really provide a framework, because otherwise we're just still doing a bit of anecdote. Still better to be together to do that. But the more that we can provide some data-based driven decision-making, I think the better the patients will do. And then third is to have a process that if things don't go as planned, to be able to review things in a joint way. Most M&Ms are actually not integrated between surgery and interventional cardiology. And I think that's something that we are working towards. Did we make the right decision up front? If not, were there things that we could have predicted? If we do that together, I think we're going to actually end up making better future decisions. So having a process to kind of recap is also very helpful.
Fantastic. That's truly hearing it from the source. So thank you very, very much, Dr. Jaffer, for talking to us about your experience in the chip space and the heart team in this month's chip update session. Thank you to all of you viewers and readers for engaging with the TCTMD chip newsletter. Look forward to seeing you next month for more exciting content. Take care.